Okay. This is going to be looking at our paper, which is about quantification of tuberculosis exposure in a high burden setting. So is that advancing? Yeah. So the way I wanted to do this was firstly to give some background on the aerosol sampling data that is from 2 studies that provide data for this paper, and then move on to the paper. So it's really a talk in 2 halves. So first off, direct aerosol sampling is, this was really the bulk of my PhD. And so based on the idea that we know that MTB is an obligate airborne pathogen, there's an attractiveness to being able to directly sample individuals with TB or somewhere on the TB disease spectrum for their aerosol specifically, on the basis that if we can determine the presence of TB in exhale breath, that potentially tells us about their infectiousness. So the system that we've developed, so you can see in the image here, it's really the end of quite a long iterative process of focusing mainly on optimizing the sensitivity of the sampling method. So individuals, participants in studies, go inside this chamber. This is somebody wearing a Tyvek suit, which reduces the amount of environmental from sort of clothing, skin, aerosol that might contaminate the sample. They then put their head into this metallic cone. So metallic, basically to reduce the amount of electrostatic precipitation, which we sort of noted to be quite an important thing. And then they can perform breathing maneuvers of our choice. So we've sort of experimented a little bit with different ways in which you can produce a sample. The collection is made by a cyclone collector and collected into liquid, which is at the cone apex. Working on sensitivity has been about trying to figure out how we can maximize the production of a TB aerosol in terms of what the participant does by way of breathing maneuver. The aerosol capture, which we've experimented with various different things, and then aerosol detection, or rather MTB detection from the sample that we obtain. And so the studies that I'm going to talk about use a research dye called diamantrailose, which has some useful properties. So it's incorporated into the mycobacterial cell wall, but that process is an active one. So you have to be a metabolically active organism in order to put this fluorescent dye into the cell wall. And then once it's in a lipid environment, you get about 1,000-fold increase in fluorescence. So this means so some technical advantages that you don't need a wash step, but also that you only light up and fluoresce organisms that are at least viable enough to be able to take up the dye. So this study, the studies that I'm going to talk about, were performed in this informal settlement called Masiphumelele, which is a sort of peri-urban area outside of Cape Town. So you can see it's not particularly large, actually, but it's quite a well-characterized population. In the Western Cape, so a very high estimated annual TB incidence in 2020 of 615 per 100,000. And we sort of know that there are really large numbers of notified cases for what's probably a population of around 50,000. And then the really useful thing about the setup that we have is that, I'll just move this out of the way, the Aerosol Research Centre, where the sampling is performed, is just adjacent to the settlement. So it's really a perfect arrangement for being able to recruit patients from this incredibly high prevalence setting. So there's been quite a lot of work that's already been done in this township. And this is from a study in 2010 that was cross-sectional TST study, and it established a very high force of infection of, I think, something like 7% in sort of peaking in adolescence around age of 15. So we know there's a great deal of TB and there's a great deal of transmission. So the first study was basically taking individuals who presented. It's both this settlement and another one nearby, but people who attended a clinic and were put into this category of being presumptive TB. So when you're, presenting in that way, you're going to end up in one of three categories. So the first would be someone who is determined to have TB on the basis of sputum that becomes expert ultra positive. Second, those who are clinically determined to have TB, but with a negative expert. And then the third category are those who aren't diagnosed with TB. So with these three categories, we enrolled all of them and then sampled at 4 different time points. So baseline, which was before starting treatment in those who were treated, and then at 2 weeks, 2 months, and 6 months. And these sampling intervals were applied to all three groups. And the objective was to determine what the prevalence of MTB in respiratory aerosol was in these clinic attendees with presumptive TB initially, but then subsequently put into one of these three groups. So I'm going to be talking sort of for the next couple of slides about groups A, B, and C. So these are the results. So the image on the left are quantitative counts. So again, group A, expert positive sputum, TB diagnosed. Group B, expert negative, but TB diagnosed. And group C, not diagnosed with TB. And then sort of expressed as a binary on the right, you can see that in all three groups, we had somewhere between sort of 90 and 95 and no real difference between them. So obviously this was not what we expected. We really didn't think that we would have so many people with evidence of TB in their aerosol in a group that were not diagnosed, despite investigation and being seen in a clinic. So then the next part of this is looking at not just the first visit, but the subsequent visits. And quantitative counts on the left, you can see that in each of these three groups, there was a reduction over time. So again, this is really another unexpected finding that groups A and B are treated, but group C isn't. But you still see this sort of almost across the board reduction in bacillary counts. And then the graph on the right is again just putting this into either detected, not detected for each of the three groups at the 4 visits. So putting that into a Kaplan-Meier plot as a way to compare treated, untreated, you can see again to our surprise that there wasn't any difference between whether you're on treatment or not. So this is the first, or actually will be the second sort of piece of data that we use for the modeling study. So we identified from this that there was a time to clearance of 83 days, which we interpret as a sort of rate of 3 per year as a clearance rate. And just to sort of to note that there's something perhaps unusual about this phenotype, or well, maybe debatable whether that's true, because in sputum that it's quite well established that there's viable non-culturable bacilli make up the majority of organisms that are present in sputum. But certainly true to say that these organisms were not very easy to culture, were not acid fast, so a slightly sort of quiescent phenotype. And then the fact that there's no difference between clearance rates between those who are treated and untreated, we've sort of written about fairly extensively in this paper. But to our thinking, it suggests that there's maybe an immune-mediated process of clearance rather than this because this can't be treatment-related. Okay, so the second study that goes into data for the model is a cross-sectional sampling of healthy individuals. So from the same, exactly the same setup, so same method of sampling and the same population. So the way this was achieved was there was a geospatial randomization. So people were randomly selected or rather Earths were randomly selected. So these sort of plots of land. And everyone on the plots that were selected were then invited for sampling. So just a little bit on this. The total number, which is actually slightly different from the paper. The paper is based on a slightly smaller data set. But the total number that we looked at were 135 individuals, ages between 14 and 72, preponderance female, and 38% were quantiferon positive. And then the key result from this, which we'll go into in a bit more detail, was that 62% of these individuals who were selected, healthy, asymptomatic, were found to have detectable NTB in respiratory aerosol. Okay, so obviously this is, again, surprising results and something that demands quite a lot of scrutiny. So I'm just going to talk on this one slide about some of the assessment of how reliable this result is. So there are obviously several concerns that we certainly had that we investigated before publishing. So one issue is how much of this is definitely TB. So the diamintrelo stain isn't completely specific to MTB. So non-tuberculous mycobacterium can also take up the stain. But we, in earlier work, established that there's quite a characteristic morphology and staining pattern. And so it seems really quite improbable that this would be largely explained by other NTMs. But it can't be completely ruled out on the basis of DMN staining alone. So we have a subset of patients that were in this study that had a second sample taken. So one of the problems of working with this very porcibacillary specimen, or rather very low volume specimen, is that it's difficult to do parallel testing on the same sample. So taking a second sample allowed us to do a ddPCR, which could be targeted for RD9, which is MTB specific target. And this showed 100% positivity in this 37 patient subset. Another way in which we looked at this in a bit more detail was that as I said before, it was quite difficult to culture these organisms, but from those that were successfully cultured, where we were able to generate sufficient biomass, which amounted to 3 out of, I think, about 64, we performed a whole genome sequence, which confirmed that we did have TB and also gave us lineages. And this was from people in both Group A and 2 in Group C. Another question is there contamination of the sampling system? So this is obviously was a concern in some of the developmental work. And there was quite a lot of sort of changes in the setup, such as the cyclone collector, to make sure we could fully sterilize it, and then use of an ozone sterilization system. And then in order to ensure that we weren't having carryover, we put in place sterilization between every sampling, and then had negative chamber controls between each participant that was sampled, and then a blinding for the microscopist as to whether they were looking at a patient or an empty booth. And then one interesting idea of how this could have been a false result, specifically looking at the fact of the count reducing over time, was whether this could be a problem with the reagents that we were using. So whether there was a degradation, we're using a research dye, so it was sort of made up as a batch. And could it be that we're losing sensitivity over time? So we did an analysis looking at counts by calendar time, removing the participant and visit. So just looking against calendar time, and this really didn't explain the lower counts. Okay, so having published these 2 papers, we're obviously interested to think about what this really means. So the way I like to kind of break this down is you can say when you're detecting TB in a bioaerosol, that can mean one of three things. So the first is if you have truly TB in aerosol, then that must imply that somebody's been exposed to TB at some point. So they must have seen the organism from somewhere, and from what we know about the natural history, it has to come from another individual. So I think that necessarily means that if you detect it, somebody must have been exposed. The second thing is whether this indicates disease, which I think is a sort of a natural thing to think when you're detecting an organism like TB. And certainly clinically in this part of the world, we always assume that a positive sample must imply that they have disease. But I think particularly with this healthy community study, the fact that we found it in a high proportion of people who are asymptomatic, it makes it very unlikely that you can really say that this is always going to be disease. I mean, it's certainly possible you could have some clinical disease where you are detecting and finding them, but in most cases that really can't be an explanation for this. So I would say probably not. And then the final is that if you detect TB in someone's aerosol, does that mean they're infectious to other people? I don't think that, I mean, that was the purpose behind doing this work. I don't think it's necessarily true that you can say that's always going to be the case. It may be that the organism we're identifying is not one that sort of reverts to virulence. I think it's highly probable that it is, but it's not definitely true, and really needs a lot of further work to establish if that's the case. So the paper I'm going to talk about is working on the first idea that if you find TB in aerosol, then that necessarily establishes that somebody's been exposed. So on to the paper. So what we're wanting to do with this is really to explore the implications of our aerosol sampling findings, and on the basis that these need to be thought about if really true, and obviously they need to be replicated, then it has quite a number of implications. So what we wanted to do specifically was to try and make an estimate of the rate of exposure to TB based on these two sets of data. So essentially we have cross-sectional prevalence data, which was the second study I talked about, and then reversion rates from the first study, because it's the study where we've really done longitudinal sampling. And then we're defining exposure in this case as a conversion from having an undetectable to a detectable MTB in a collected bioaerosol sample. And just to say, we're working from the sort of binary detected, non-detected, and removing the quantitative element. Okay, so we opted to use a reversible catalytic model to investigate this. So this is the idea that you start off with a clear bioaerosol, and then at some point, in order to get to this sort of 2/3 prevalence, you must have a rate of exposure that gets there and then would establish a plateau. Again, I'll come to the assumptions for that plateau. So we're calling rate of exposure lambda. So this is, I've tried really explicitly in the paper not to confuse this with force of infection, because we're obviously talking about something different from infection as that's normally characterized by positive TST or positive IGRA. And then rho, which is the rate of reversion. So this is the model we're using. So a saturating exponential function that uses the two rate of exposure and the rate of reversion to establish seropositivity for a given age. And then this lambda over lambda plus rho is the saturating prevalence. And I should probably just say, looking at this, that once you have high lambda and rho, or at least above 1, then that sort of part of the equation to the right tends towards 1. So you could almost simplify this down to just lambda over lambda plus rho. So the assumptions that we're working on are that people are all varicella negative at birth. So we're really trying to make this a nice, simple model. The entire population is susceptible, and that we have a rate of exposure that, at least for the primary model, that's independent of age, and one that we're not looking at any changes over time, over calendar time, and then no component of seasonality. The rate of reversion also we're keeping constant. And then I think quite an important one actually is that if somebody converts to a bioaerosol positive state, that this is due to exogenous exposure, and it's not a sort of a cyclical recurrence of disease that they're already infected and then they just have a recrudescence. So the method we used was a Bayesian inference approach to fit this reverse catalytic model to our prevalence data. So this is prevalence data of healthy individuals. And we used the Markov chain Monte Carlo with Gibbs sampling to achieve that. So our clearance half-life of 83 days, we interpreted as a reversion rate of 3 per year with a confidence interval of 1.5 to 4.0. And to incorporate this, we use this as the prior for the reversion rate row. And again, because we're not trying to, we don't have a great deal of data, so we just use the uniform distribution for that. And then because lambda's the parameter we're interested in, we left that as an uninformative prior between 0 and 10. And then using fairly standard measures to determine convergence of the chains, which was easily achieved. So a Gelman-Rubin statistic of less than 1.1 and an effective sample size of greater than 200. Okay, so this is essentially the result. So I'll just talk you through this plot. The dark points with the error bars are the age-specific prevalence data that we have from the second study that I discussed. And then overlaid on that is the median prevalence estimate that came from the model. And that's the dark blue line. And then the lighter blue are the 95% credible intervals. So this gave an estimate from the posterior distribution of an exposure rate that had a median of 5.1 per year with these fairly large credible intervals, but still high at 2.5 to 8.5. And I mean, overall, to sort of understand how this would work, this would suggest a cyclical pattern of aerosol positivity and clearance with a period of only a few months. So you would expect individuals in this population, if this is true, that within, I think it's about 2 months or just over 2 months would from being negative would end up positive, and then after a slightly longer period to lose that positivity. So then essentially I'm moving on to some sensitivity analyses, and this I'm going to present first, which was I think probably the most important. So it's looking at the model that a model without having the reversion element. So how the model would fit this data if you sort of assume that the majority of healthy people don't respond to having a positive bioaerosol in the same way that the symptomatic individuals do in the first study I talked about. So it could be that, you know, it's unlikely that there's going to be no reversion because we already witnessed some reversion, but just really to sort of fully explore the parameter space, this would be the as low as you could go. So a model with no reversion produced this plot in terms of the seropositivity. And so the reversion rate here would be basically suggesting that healthy people don't revert and remain lifelong positive. And so if this were the case, this would give a much lower rate of exposure of just 0.03 per year. But really the point of presenting this is that we think visually it's pretty apparent that this doesn't fit the data particularly well, limited though the data are. And so this really predicts the data less well than the reversible catalytic model. And with an information criteria, this was shown to be higher with a worse fit. So higher, I believe, with this information criteria is fit, but also accounting for complexity. So even though it would be a simpler model, you would have a considerably worse fit. So essentially suggesting that there has to be some, or it's very likely there would be at least some form of reversion, and therefore a rate of exposure that would be higher than that. So the next sensitivity analysis was on the basis that we think we're sort of as high a prevalence as probably exists almost anywhere in the world, but most other settings would have a presumed much lower bioaerosol population prevalence. So using simulated data where you plateau your prevalence at these different points, so less than the sort of 0.65 or 0.62, I think it was, that we found in the actual data. If you imagine that you had a much lower prevalence of 0.1, 0.2, 0.3, or 0.4, and then using the same prior, the idea that the rate of reversion is something that's biological, not necessarily related to environment. So using the same prior, you then have a range of different rates of exposure, varying from 0.3 to 2.0. So this was just to highlight that the rate of exposure is very sensitive to whatever the bioaerosol population prevalence might be, if we get to the point where we actually have data for other settings. Okay, and then the final one really is just to highlight this idea, which is almost certainly the case, that you'll have a different exposure at different ages. Undoubtedly, in childhood, people will probably be exposed considerably less. But this was to highlight that even if you have no exposure up to the age of 10, this doesn't make a significant difference to the rate of exposure estimated from the data that we have. Obviously, what you would really want is to be able to sample children, younger children. But we've sort of established that we can't very easily do that at all, given the kind of setup we have at the moment. That's not conducive to recruiting children. Okay, so a few conclusions, and then we can have a discussion. So the findings that we have, so really based on the longitudinal data that we have, imply that there's a very high rate of TB exposure. But I think that is specific to a hyperendemic community. It suggests that there would be rapid cycling between bioaerosol carriage and clearance. But I think that the way, at least my way of thinking about this, is that this exposure and colonization of the respiratory tract is something that's really, I mean, independent's probably the wrong word, but it exists in differently from sort of TB infection that we're all used to thinking about, defined by immunoreactivity by the TST or IGRA. So this may be it suggests from this model that it's a transient phenomenon that people may. I really like thinking about this as colonization, because to my mind that's fairly biologically plausible. It's in keeping with other mycobacteria, and so the idea that you can have people colonized in their respiratory tract with an organism that, although often virulent, isn't necessarily virulent, is sort of in keeping with what we see across microbiology, really. So the main caveat to this, which we talked about in the discussion, is that we're basing a rate of reversion or rate of clearance only on people who are symptomatic, and it may well be, and I suspect it probably is, considerably different, maybe a lot less in those who are asymptomatic. And if this is the case, this would lead to an exposure rate that's somewhat lower. And so we would obviously want to explore that further. So the sorts of things, I'm not going to talk in detail about some of the implications, because in a way we're sort of presenting this as this is sort of tentatively what we think is something that we should think about. But to my mind, what you'd want to know from this, if we really think of this as colonization, then the questions that raise would be what leads someone who has a positive bioaerosol to develop infection and then disease, and is that something we could intervene on? And then also, what are the mechanisms of clearance, and is this something that we should be thinking about more when it comes to what our drugs for latency do, what the impact of vaccines might be, and is this something that might be valuable in general for reducing TB burden? Okay, so limitations, there are lots, but I've only put 2 points really. The number one is that we're basing all of this on work that's done from our sort of aerobiology lab in a very unique setting. So obviously we'd be very interested if we could establish similar findings in different settings. There are other approaches to sampling aerosol that have found, to some extent, in subtle ways, intriguingly similar results. But I don't think there's any other approach that you would expect to be as sensitive as the one that we're using. Yeah, and then the thing that is sort of would answer some of the questions that I've talked about is if we had more longitudinal data sampling asymptomatic individuals, and we would want this both in our setting and in other settings, and then you could directly establish whether there's what the rate of acquisition of a positive bioaerosol and the rate of loss of a positive bioaerosol. So there's sort of future work that is going to address some of these things. I've been supporting an application for a PhD candidate to look at both index cases and household contacts in Cape Town and London, and this would be using exhale breath. So one of the problems we have, I think, is that we have a very high tech setup that isn't easy to replicate. And especially with the sort of funding situation at the moment, it's been difficult to I think find people who'd be willing to support the work. And so a big advantage would be to simplify this so that we can have not a sort of a bespoke lab, but a setup where you could sample people in a normal clinical environment. And we've been working on an exhale breath condensate type system, which in the past has never been particularly successful at detecting TB, but with some modifications may end up being not as good, but perhaps another way of getting equivalent data. But it's not an easy specimen to work with, so it might well need a lot of work. The other thing is we obviously want to try and understand more about what having a positive TB, MTB bioaerosol means. And the full characterization, I think, involves probably doing cross-sectional imaging of some of these asymptomatic individuals and really establishing, do they have any evidence of disease? I mean, have we an alternative idea could be, is there just a huge amount of sort of not clinically apparent disease, or should we actually be thinking about this as airway colonization? Okay, and then the sort of the final bit is, as I talked about earlier, trying to explore the infectious potential of this phenotype. So that it's definitely technically difficult, but one area would be of interest would be trying to maximize the sample yield, both by sampling method and probably by culture method. to maximize the biomass so that you could generate a whole genome sequence. And then that might help you to get at this idea of can you demonstrate transmission from the sorts of people that we've identified in this study to somebody else. Although obviously with the slow molecular clock, it doesn't make that particularly easy either. We've also thought about exploring individuals in lower prevalence settings, so that therefore it's easier to demonstrate transmission. And finally, I'm not sure if I'm too supportive of this, but the idea of using in vivo sampling or guinea pig sampling might be something that would need to be considered. Okay, so yeah, with that, I'd just like to acknowledge all the work that's been done by people in the aerobiology unit in Cape Town, and also supported strongly by microbiologists at UCT. And for the model itself, Prof. Frank Kobelans and Sabine Hermans have been my PhD supervisors at Amsterdam Institute of Global Health and Development, who've really helped me develop this. So happy to take any questions.
Brilliant, thank you so much. That was fascinating, and I have a lot of thoughts and questions, but it was really interesting. I saw Pete had one in the chat already. I don't know, Pete, if you want to kick off.
Thanks, and yeah, that was really interesting and somewhat discombobulating. So yeah, and apologies if I missed it because I have to step out for a minute at some point. But I was just wondering if you, as part of this or other work, have got kind of any follow-up of individuals who were test negative. And the reason I ask is because, you know, if you're thinking about mechanisms that could generate a kind of saturation in a, you know, cumulative infection curve over age, then another one would be that there are some people who are just resistant to becoming infected. So it would be interesting, I guess, if that hasn't been done, to think about the people you found who were negative and do they actually convert?
As in, are there people who are persistently negative? Yeah, we haven't done that work yet, but I agree it would be interesting. I would sort of feel that it would be unlikely that people would, I mean, if, again, thinking about it as colonization, that you would be resistant to colonization as such, because I think what we've been able to show, I don't know how clearly it came across, but a lot of the individuals that were in the healthy community study were quantiferon negative, but bioaerosol positive. I mean, probably about half of them. So to my mind, that's really what makes the idea that this is colonization more appealing, because it looks like they just have organism in their respiratory tract without really triggering the immune system. I mean, obviously there'd be more ways of looking at that than just quantiferons, but if you think about having Staph aureus on the skin, I don't think there's a sense that you would have someone who's resistant to that. I mean, maybe I'm a bit naive when it comes to immunological mechanisms that affect mucosal surfaces, but yeah, I mean, an interesting thought, but yeah, we haven't done that yet, but it's clearly something we could do.
Thanks, Pete. Florian, I think you were up next.
I hope so. I didn't actually follow the test. I don't know if you were first. Sorry about that. I have two questions, but first, man, thanks so much. This is such an exciting seminar and really exciting work, which I feel like we're learning more about the tricky things. And so this is really great. My first question is, you mentioned that that you did IGRA, and I was just wondering whether you found an effect of being IGRA positive versus finding bacteria. And the second question is, if we assume that not all of the bacteria are culturable, so some of these might not be culturable, could it be that there is some sort of effect that if we have somebody who doesn't have symptoms, who has been maybe colonized, and then somebody else gets exposed to that person, that those are bacteria that are less likely to cause disease in the other person, if that makes sense. Is there any reason to believe that, or is that not possible to say? Thank you.
Yeah, no, I mean, I think great questions. The first, sorry, I'm not sure if I fully remember it, but you're saying, did we identify people who were IGRA negative, but still had positive bioaerosol? I mean, that's certainly the case. So we almost put people into different categories. I mean, I think the way we think about this is that you seem to have people really across the spectrum, all the way from active disease with a high bacillary burden in sputum to people with probable disease with no bacillary burden in sputum, to symptomatic to asymptomatic, and they seem to have, at least in this setting, a high proportion of them seem to just have positive aerosol, slightly higher in those who are symptomatic and have disease. But in terms of IGRA positivity, we're sort of down at about 40% IGRA positivity in the healthy asymptomatic individuals. So roughly about half of those that were positive were IGRA positive as well, and the other half were IGRA negative. If that makes sense.
So just to pick this up, because I'm just wondering if you see an effect of IGRA positivity on the bacteria that you see in the bioaerosol. So in other words, I'm wondering whether producing a sufficient T cell response that gives you a positive IGRA could somehow have an effect on clearance.
Well, yeah, I mean, I suppose we don't have that, but it is telling, I think, that you have a high IGRA rate once you become symptomatic. So sort of our way of putting this together is the individuals who are group C, who were not TB diagnosed, but did have this high positivity, but they were symptomatic, is the fact that they develop symptoms I mean, it could be that they are at that point perhaps converting an IGRA, but it's that the symptoms and the clearance are part of immunological process. So it's an immune mediated sort of response to the organism that leads to clearance. I mean, it would need a lot of work perhaps to establish that, but it would obviously be interesting if that were the case of something that you could intervene on as a process. So, you could support the process of clearance, let's say. I think then your other question about whether these sort of quiescent, poorly culturable organisms could transmit to somebody else and remain sort of, again, non-virulent, sitting in their aerosol. I mean, yes, maybe. I mean, it's only speculation, but I think that's another thing that you want to know is, are these organisms that can, do they invariably become virulent, or do they sometimes just sort of sit there quietly?
Yeah. Thank you. Yes.
Thanks. Just want to echo Ben. That was a really great presentation. I feel like I learned so much. My question is, so in the model, it looks like the calibration was suggesting something on the order of 5 exposures per year. And in your data, when you followed people who were bacteriologically negative, not given treatment, so group C, it looked like most people were kind of cleared by the end of the 6 months. I didn't see a lot of people kind of jumping back up during that time, although I might have missed it. Do you have a hypothesis for why we're kind of not seeing that 5 exposures per year in the data? And do you think you would see that jump back up if you followed people for a longer time?
Yeah, we have thought about that. I mean, I think there are a few cases where we saw a sort of potentially a jump back up, which could be a re-exposure. And I did, again, not not published, but a sort of additional look at these. They're only about 30 people, so you would expect some, who would become positive again. But we had a look at, we could basically get access to lab data, so people who obviously represented and had a gene expert. And there was at least one or two who ended up with positive gene experts, which is not the same thing as positive bioaerosol, but it sort of implies that there probably is some, if you followed them out, that you would expect there to be some positives again. But yeah, I mean, it does make you wonder whether, having gone through a sort of a symptomatic clearance, puts you in a slightly different category. I mean, it's all very speculative, though, really. So, but yeah, I mean, we definitely did worry about, if this is if this sort of exposure rate is what you'd expect, then shouldn't we be seeing more in sort of within the 6 months of people sort of bouncing back? I mean, because another way of looking at this is they don't fall back to the level that the asymptomatic population was at, as in they went from about 90% positive down to about 20%, whereas the sort of healthy people are at about 60%. So yeah, interesting.
Yeah, definitely.
Yeah.
Thanks.
A lot of it very difficult to get your head around. Kristen.
Yeah, again, thanks so much, Ben, for this presentation. I think really interesting contribution to this sort of emerging idea of carriage of MTB. As you said, kind of consistent with what we know about the natural history of a lot of other respiratory pathogens, but we really haven't understood or appreciated for TB. I guess I did miss the first few minutes, although I have read your nice paper. So I hope I have a somewhat full picture of the data that you used. So I'm so sorry if you said this, but my question is, the data that you drew on for the bioaerosol sampling was done on you said asymptomatic folks. And I just wonder, when you say that they were asymptomatic, did you do any sort of more objective symptoms or sort of more like deeper symptoms screen than just asking people whether or not they had symptoms? And I asked just because when we're talking about asymptomatic TB, like much of what you like the definition of that sort of depends on how you define asymptomatic. Is it that people don't like sort of have symptoms, but just they don't quite rise to the level of seeking healthcare? Is it that people have like are truly symptomless, and just sort of what you know about the symptom profiles beyond just just characterizing it as asymptomatic?
Yeah, no, the answer is no, we didn't, but it would definitely be interesting. I mean, I agree. We at some point we had some data which involved sampling people where we were doing cough counts using sound recording and a sort of a machine learning algorithm to determine what was a cough and what wasn't. And what was quite remarkable, this is sort of not published anywhere, but people, whether or not they said they had a cough was really unrelated to whether or not we, after listening to them for an hour, whether or not they did cough. So I agree. It could well be that people who don't admit to symptoms do in fact have symptoms. I mean, it does. The fact that we had such a high proportion of people who were just recruited from a community at random, makes me find it hard to believe that they're all harboring disease because it's such a high proportion. But yeah, I mean, it would obviously be useful to explore that a bit more. And I think objective measures of symptoms, or well, there'd be signs would be useful, but cough in particular.
That's actually, I mean, it was a very minor point, but sort of touches on something that I was thinking about, which was that you had your sample was 64% female or something, and I wondered how much this was, how much people it was exposure to, men who weren't in the household or weren't in the plot of land or whatever at the time that was causing the sort of that's where the exposure came from. I just wondered about that.
Yeah, I mean, I think we suspect that. I mean, it could be that women are more interested in taking part in a study, or perhaps more available. But also, I think at the time people recruited, it may be more likely that they were sort of on the earth. Yeah, I mean, there's all sorts of. I mean, in a sense, this is again a problem of not having enough data. That although we had 135, I think it was. If we had a greater number, then we might be able to explore that a bit more. And we did some sort of very preliminary work, seeing whether there was a clustering effect, because obviously we're collecting people who are on the same Earth, so they're within the same household essentially, or neighbouring households. But I think any kind of analysis like that is just problematic because of the low numbers.
Yeah, and I guess related to that a little bit, I was interested to see you looked at that sort of change in. You made that assumption about changing exposure if there was less in children, but I wondered. We'll often use contact matrices to look at how people might come into contact with each other, effective contact rates, and that varies quite a bit by age. And I wonder if that might be I suspect from what you showed that it wouldn't be hugely different, but I think doesn't effective contact, often drops off with age as well, with older age groups. And I just wondered if would be an interesting thing to explore a little bit. I don't know if it would be possible, but who people are coming into contact with, and a bit more about a bit more dynamic than just not the same or nothing until your age 15 or whatever it was, and then the same.
No. I mean, it's the trouble really with all of this work is that it's expensive, effectively, to get samples. So. And you want as many as you could get. So trying to do that efficiently is I think the aim here. The idea of a simplified system, you probably ultimately just lose sensitivity as well. But it may still be better to have a system that's a bit less sensitive, but you can sort of apply across a much larger population, or generate a much larger sample. But yeah, then you could look at questions like that.
Yeah, sorry. I mean, I think what I was thinking about was rather not in the data collection, but on the modeling side, because we have some of these, particularly for townships in South Africa, there are some of these contact surveys that give you an idea of that sort of effect of contact, or the contact rate that people have. I don't know if it doesn't translate over directly to exposure necessarily, but it might be interesting.
I mean, yeah, no, it certainly would be, I think.
I see we've actually only got like 1 or 2 minutes left. Does anybody have any last questions? If not, maybe I can, as a last question that and I think you've touched on bits of this, but you had, at the end of when you were telling us about the data, you had something where you said that you had those, what does bioaerosol positive tell us? Exposure, yes. Disease, probably not. And infectiousness, you had sort of, I can't remember exactly what you had, but so my reading of that was that then could be infectiousness just from people who are bioaerosol positive but don't have disease. Is that what you were suggesting with that?
Yeah, I mean, well, that's what I think we need to explore. I mean, we are able to generate these positive samples without people having symptoms. So it makes you think that you don't need symptoms in order to shed these organisms. So therefore, there's not a good reason why you can not be an asymptomatic transmitter. And there's no difference between the samples we were getting from the people with disease, so the sort of group A's, and those who, I mean, they were a little lower quantitatively for the healthy individuals, but still, positive. And so, I mean, I think that's something that we feel we should explore. And also, I mean, the sort of the flip side of saying that there's high exposure is where does the exposure come from? And so it might, I mean, it's tempting to speculate, but sort of exposure from people who don't even have evidence of disease or, you know, sort of subclinical obviously is a hot topic. So whether they're transmitting would be interesting, but we haven't quite got there with this, I don't think.
Yeah, I mean, does that mean that even asymptomatic is not enough when we have all sorts of TB just floating around from, you know, an even bigger pool of people? That is time though, on the hour, so we should probably wrap up. But I think, you know, we can tell from the number of questions that was really interesting. Thank you so much, and thank you everyone for joining as well. We don't have a seminar next month because hopefully many of you will be at the Union conference. So hopefully we'll see lots of you in Copenhagen, and then see if we can find time in the middle of December, not too late, for another speaker then. But thank you again, Ben, and thank you everyone for joining.
Yeah, thanks very much.
Thanks.
Yeah, bye.